Good afternoon, ladies and gentlemen, and thank you very much for your kind invitation, Carl and Daniel. This presentation is focusing on plague in Madagascar and on the health risks and climate changes. Plague has marked human history in a unique way during three historical pandemics. And the third pandemic emerged in the natural cradle of the Yunnan province in 1855 and reached Hong Kong in 1898. Thanks to long-distance steamships, the third wave established Yersinia pestis in sustained episodics all over the world, and it's occurred in areas previously free of plague. Also, the third pandemic took millions of lives and disrupted societies. Although the disease eventually died out in the vast majority of the world, thanks to adequate sanitary mitigation measures, some exotic foci established during the third pandemic. And nowadays, Yersinia pestis remains present in at least 33 countries where signs of activity have been detected in the last 30 years. Occasionally scattered cases of human plague are regularly detected in China, Mongolia, the Russian Federation, Kyrgyzstan, Kazakhstan, Peru, Bolivia, and Western United States. When in the mid-20th century, cases were mostly reported from Asia with steadily decreasing trend, a sharp increase was observed in Africa from 1980s to the present day. Between 2013 and 2018, 2,886 cases and 504 deaths have been notified to the WHO, with a reported case fatality of 17.5%. 95% derive from sub-Saharan Africa, mainly in Madagascar, and to the region of the Democratic Republic of Congo. Plague first arrived in the island, Madagascar, in November 1898 at the port of Tamatave, nowadays Toamasina. And the history of plague is strictly linked to the history of the Institut Pasteur of Madagascar, which was founded in 1898, only a few months before the arrival of the disease. Its first director, Dr. Thiroux, arrived in Tamatave in January 1899, just a few months after the first outbreak. He was perfectly aware of the discoveries that were made by Yates in 1894, by Simon in 1898. Yates had discovered the etiologic agent of plague, and Simon had discovered the role of fleas as vector of the disease. And with the help of Dr. Kermougan, a physician who lived in Tamatave, Dr. Thiroux set in place the first prophylactic measures. Following the construction of the railroads, whose inauguration occurred in 1913, the disease progressed, unfortunately, in the inner areas of the island. It abruptly entered the capital, Antananarivo, in June 1921, and in 3 weeks, 48 individuals belonging to two families who had unfortunately met for a meeting died of pneumonic plague. From the capital, the disease spread rapidly throughout the Central Highlands. The population was deeply scared, of course, from the lethal cause of the disease, and was also scared by the sanitary measures that were imposed. Isolation of infected patients and of their contacts in lazarettos, destructions of the houses that were set on fire, establishment of sanitary and mitigation measures. However, the population was traumatized by the measures which interfered with the traditionally funerary behavior of exhumation, which is called fama di Hana. This was done in order to prevent rapid spread of pneumonic plague during the burial practices, and burial in private graves were forbidden. However, this led the population not to declare to the local authorities new cases of plague in their families, and of course, the relevant number of deaths. The new director of the IPM arrived in 1925, was called Georges Giraud, and he decided to maintain all the measures that were applied by his predecessors. He also quite compulsory post-mortem examination of the patients suspected to have died of plague, and biopsies were the spleen, liver, lungs were routinely taken and examined. Since 1899, different vaccines had been used to prevent plague with little success, and Girard demonstrated that vaccines based on the inoculation of dead bacilli were not efficient. So together with Dr. Jean Robic, they developed a new vaccine based on the use of live attenuated bacilli, which was called EV, and this was discovered in 1931. The EV vaccine had a high immunization power, which lasted nearly 9 months. Between 1932 and 1934, the EV vaccine was tested on volunteers, and at the end of 1934, the first national campaign of vaccination against bubonic plague started from the capital and extended to the rural areas of the Central Highlands and then to the rest of the country. And the number of bubonic plague cases from 3,500 per year with 90% death rates dropped down to 200 at the beginning of the 40s. So the vaccination became compulsory in 1940, and despite being mandatory, a decrease in the number of vaccinated people was registered. Why? Because the population was unhappy to receive the vaccine, also because unexpected reactions often occurred, and because some of them developed plague. In the same year, there was an anti-vaxxer movement that spread the voice that plague was a non-existent disease, such as the COVID-19 today, and that plague was a political and racist disease. The EV vaccine was used until 1959. Quite luckily, I say, in 1938, sulfonamides were introduced in the treatment of plague in Madagascar, and since 1947, more than 80% of patients affected by bubonic plague had a complete recovery. The real therapeutic revolution was introduced with the discovery of streptomycin, and it was introduced in the treatment of bubonic plague, in bubonic and pneumonic plague in 1947 by Estrada. The same year, DDT was used for the first time in plague endemic foci. A DDT-based powder was spread in houses and in their premises, and the huge use of insecticides and increased sanitary measures in the lower areas around Antananarivo led to the elimination of plague from the capital in 1950. So we had in 1950s marvelous situation from an epidemiological point of view, because plague was brought under control in the island by a combination of vaccination campaigns, including housing and hygiene measures, and the discovery and use of streptomycin, so antimicrobials, and insecticides DDT to control fleas. During the following 30 years, 20 to 50 cases were reported for the entire country. However, in 1989, more cases were reported, and the number of suspected cases started to increase steadily. Therefore, a plague national control program was established in 1993, and since then, each suspected human case has to be immediately reported to health centers, and confirmation of cases suspected plague cases occurs at the EPM plague unit in Antananarivo. So what do we talk about the plague enigma and its relation with climate change and health risks? First of all, the Malagasy population is growing fastly. We have 29 million of people in 2022, with 61.1% living in rural settings in extreme poverty. Half of the population is younger than 6 years, and it is affected by multiple infectious diseases and malnutrition. And the median age is 22 years. Madagascar is one of the poorest countries of the world, and it is the nation which has already directly experienced the effects of climate change, although not all scholars have reached a consensus on this. Most governative and non-governative organizations have observed that the climate
it's 7 hours
impacts directly on this population. Here, important sectors including agriculture, water supply, fisheries, transportation, health, biodiversity, and livelihoods are interconnected and highly vulnerable to the threats of increasing temperatures, sea level rise, precipitation, fluctuation, rainfalls, monsoons, and changes in severity and frequencies of climatic extreme events. As you can appreciate from the slides, Madagascar shows an extremely peculiar topography with marked biodiversity. In the center of the island center plateau, which is called Central Highlands or Haute Terre, which ranges in altitude from 750 to 1,500 meters above the sea level. These areas are the most densely populated part of the island and are characterized by terraced, rice-growing valleys lying between green hills. Rice and grain are cultivated here, and these are the area where plague endemic foci are active and where each year seasonal plague outbreaks occur. The southeastern, southwestern regions of the island are those that are suffering the most dramatic climate changes. Recent estimates indicate that 1 to 1.5 million people, especially in the south, are living in food insecurity, and that 1.3 million people suffer from acute malnutrition, which affects mostly children, as you can see from the slides. Extended drought periods and increased variability in rainfalls have caused soil infertility and harvest losses up to 95%, forcing 1 million people to become food insecure and then, of course, to leave and migrate. So thousands of people are living in the south and are migrating towards the regions where agriculture can still be practiced, such as the Central Highlands. From an epidemiological point of view, having more people spending more time in agricultural landscape creates greater risks of contact with rodents and the fleas. Food scarcity has also been correlated to changes in food practices, such as storing grain close to or in the house rather than away from the house. And this, again, unfortunately, brings rodents and their fleas close to people. It has to be underlined that the maintenance of Yersinia pestis in nature and from where it spreads to cause human outbreaks render it impossible to eradicate. We have to point out that the true number of species implicated in plague transmission and the true composition of reservoirs and accidental hosts is unknown. We do know some reservoirs and vectors in Madagascar, such as Rattus rattus, Rattus norvegicus, the Asian shrew, Suncus murinus, and vectors like Xenopsila chaopis, Xenopsila brasiliensis, and Synopsilus concernei, which is an endemic species. However, we see that the ecology of plague in the highlands, as far as the urban area are concerned, is different from that of urban area in the lowlands. For instance, let's compare Mahajanga, the port on the west side of the island, with Antananarivo, which is the capital located in the Central Highlands. In the lowlands near the port of Mahajanga, the Asian shrew is involved in the transmission cycle, and outbreaks have occurred during the dry season, usually in July-November. The vector, Synopsilus concernei, is an endemic species and is found on the fur or within burrows of black rats, living outside the house, but also in open biotopes and in forests. It shows a great transmission efficiency, greater than that of other fleas. Restriction of plague primarily to highlands is probably caused by the absence of Synopsilus concernei at elevations higher than 800 meters. In the central and northern islands, over 800 to 1,500 meters, the black rat and the grey rat are the main species involved in the transmission of plague. We have a predominance of Xenopsila chaopis, which is found on black rats that live in the houses. Here, the human plague season starts with an early recrudescence in September, shortly after the summer monsoon, of course, peaks in November, ends in March, April. A close link exists between the seasonality of human plague and the movements of rats between houses and rice fields, and it is related to the harvesting season and the use of slash and burn cultivation. Most of human plague cases often occur also in underpopulated and remote rocky areas in the highlands, and these are the areas where access is particularly difficult. Here, therefore, true case numbers of human plague may be underestimated in several areas. Cases may arise also in a community with a high degree of stigma linked to plague and therefore be hidden from local authorities. Between 1998 and 2016, death was more common for pneumonic plague case patient who had recently traveled to an endemic region, as shown by a field investigation. This field investigation found that index case patients had often traveled long distances, 50 to 200 kilometers, between probable places of infection and their own villages. And the same findings were found in the Democratic Republic of Congo. Especially more confined plus-presented cases during 1998 and 2016 were confined to Central Highlands, but some occurred in regions where plague had historically absent. An outbreak of bubonic plague emerged in southeast Madagascar in the district of Befortakra, outside previously known limits of plague endemic foci. The outbreak began in August, but since Befortakra is remote and lacking basic service such as telecommunication and health facilities, health officials only learned about the outbreak in November-December 2016. It is not clear whether plague has always been present in this region, which are also the poorest regions of the country and the most exposed to climatic change, and not previously detected or very recently transported to these regions. For sure, we know that imported bubonic plague caused by human movement or transportation has been documented for Mahajanga in the 90s. Between 95 and 98, Mahajanga is a coastal location outside the traditional regions of plague in Madagascar. Here, 1,702 suspected cases of bubonic plague and 507 confirmed cases were identified with 40 deaths. 2 of the isolates from 2 distinct patients show resistance to antibiotics. Plague circulated in the local Asian shrew, Suncus murinus, who lives in the houses and in the outside, but was also transmitted to humans through the black rat, which exemplifies the surprising adaptability of Yersinia pestis. Plague has circulated in Austin fleas in Mahajanga for several years before apparently disappearing. However, since plague can occur in new location in Madagascar, clinicians and authorities are aware that traditionally plague foci have to be controlled. Plague grasped the attention of the scientific community when an outbreak of important pneumonic plague from the remote rural areas was declared in Madagascar in September 2017, primarily striking the capital, Antananarivo, and the main seaport of Toamasina. 2,417 cases of plague were confirmed, causing the death toll of 209. And a total of 1,878 clinical suspected pneumonic plague cases were identified. This confirms that there is a connection between rural and urban areas in plague transmission, which is a major concern that has to address to avoid urban outbreaks. The reduction of the discontinuation of surveillance program and exacerbation of poverty and poor sanitation are important factors in the emergence of human cases. This episode in Antananarivo and in Toamasina should be considered an echo of the first pandemic, which first established plague in Madagascar. Given the high lethality, the capacity for social disruption, increased connectivity between endemic and urban areas and international transport, plague should be considered a neglected threat that needs renewed attention. For all the above reasons, plague surveillance and case management in endemic regions are constantly performed to allow to detect early case and treatment, because this leads to favorable outcome, and also early warning of human plague occurrence outbreaks are needed. Accurate quantification of disease burden and geographical distribution, especially in a period of huge migration due to climatic changes, are recorded. The apparent unpredictability of plague recurrence and reemergence highlights that the eco-epidemiology of plague is still poorly understood, and this is a matter of great concern for public health officials everywhere in the world. More research on surveillance, ecology, human behavioral intervention is urgently required, and there is also a need for anthropologists and social scientists who may provide insights to mitigate distrust, increase cooperation, and community communication. So this is a cross-cutting research that should be linked to the paradigm of One Health, which is grounded on the concept that human, animal, and environment health are all deeply intertwined. Human plague is an excellent example of this interdependence. Improving human living conditions in plague endemic areas, both through environmental and behavioral intervention, might really be the most effective way to avoid plague cases, and in the meantime, to reduce environmental degradation and improve ecosystem resistance. Thank you very much for your attention.